This episode was recorded pre-lockdown back in February 2020, before social distancing was applied.
I'm Nicola Garda, and my work in broadcasting at the BBC gave me a real passion for the telling of stories. I think being able to connect through something which we all have in common creates a conversation where we can invite everyone to join in, and perhaps then we don't feel so rare after all.
I am Maria Angels Ferrer, and I have also a real passion for stories, hearing them and sharing them in ways that makes us all feel better about ourselves. Besides having an accent from Catalonia, I consider my job to be a detective of preferred stories. Hopefully, this becomes clear as we all listen many different stories.
So we're talking today with Dr. Fiona Ulf. Fiona is actually part of our team, and she's a chartered health psychologist, and she looks at the communication and impacts of when you're talking to patients and you're giving them a newborn screening diagnosis, the impact that has on their parents and on the child. Mm-hmm. And then we have Professor Rebecca Bennett. She's a bioethicist, and she works quite closely, I think, with Fiona on different papers and research, and she's got a great deal of experience with healthcare education and with public engagement, and again talking around informed consent. Mm-hmm. And Professor Kevin Southern from the University of Liverpool, and I think he works at Alder Hey Children's Hospital. Mm-hmm. And he particularly has a specialism and interest in cystic fibrosis care, but again has been involved with newborn screening, particularly for cystic fibrosis. But I think that has expanded out to the ethics and the communication of newborn screening.
So we have a bunch of professionals today, really, and I think we hope we can keep the voice of people that might live with some of these conditions, or they go through screening at this point, or their parents, their mothers, fathers, and I hope that we include them in the conversation.
Yeah, and I think that was something that we were concerned about, both of us, wasn't it? That it would have been ideal possibly to have the voice of somebody that had been through either newborn screening but I think hopefully what we're doing is opening it up to everyone then. Like, we're not choosing a particular person to come and be the voice, but actually we're saying to our listeners and to anybody that wants to engage in the conversation to engage with us with all different voices and opinions on this matter.
And anyway, both of us have been through childbirth, and maybe we can think about our own position.
Exactly, and I love talking about that.
Well,
so
let's see.
I think we'll both get our say in terms of our own experiences and our kind of ideas on what our experiences were and how that could have been different, maybe.
Let's go.
So, welcome to another episode of our podcast series, Rare. And in this episode, myself and Maria Angels will be talking to Dr. Fiona Ulf, Professor Rebecca Bennett, and we have Professor Kevin Southern joining us from Liverpool University. And today we're going to be discussing, probably amongst other things, but How Rare Is Your Baby was the title originally of our podcast, and thinking about the psychological and ethical issues of newborn screening. So I think it'd be useful at first if we could start with you, Fiona, just to introduce yourself a little bit and why you're here today, or what you are here to have a conversation about.
So my name is Fiona Ulf, and I'm a health psychologist. I have always been interested in how people make decisions about their own healthcare and how the information we give them can help them make those decisions, but crucially how it can alter how they adapt to the situations and decisions that they're having to make. So I became interested in newborn screening about 2 decades ago now, because I was interested in how children make sense of novel aspects of the NHS. So at that point we were just beginning to look at a national newborn screening programme, and I was interested in the kind of results we were going to be returning on children and how they would make sense of that when the general thinking was that children didn't fully understand genetics.
And Becky, could you introduce yourself?
So I'm Becky Bennett. I've been working in bioethics for 26 years now. I kind of fell into it. I used to be a primary school teacher a very long time ago and saw an advert at the university and didn't realise that primary school teachers don't apply for jobs at the University of Manchester. But I did anyway and got the job and was working with a very famous bioethicist called John Harris, who did lots of work on disability and all sorts of things. But I was on a project looking at HIV, actually. That's where my interest in this whole area came. And looking initially at screening for HIV in pregnancy.
Slightly intimidating for me to be with Becky and Fiona, and who proper sort of wide thinkers on this subject. But I'm a children's doctor. I work in Liverpool. I've been involved in the care of people with CF children since 1989, so that's quite a long time. But for the last 20 years, I've been a consultant in Liverpool, and I work with the cystic fibrosis team there, and we look after a large number of children, about 350 across the northwest. But I've had a growing, sort of over the last 20 years, growing appreciation of the balance of screening, and there is a great positivity around it, but there's also significant impacts which are really quite difficult for families. And a lot of my work over the last 10 years has been kind of focused on that, really, some of the difficult dilemmas that families are, the position that they find themselves in, and trying to sort of improve it through clarity of information and so on. But it's been a fascinating journey, and a sort of realization of me as a doctor. We're kind of like to diagnose things and manage things. We don't like much greyness, but actually the world is a very grey world, and so it would be interesting to talk about that.
Definitely, and that's something that we will explore, and particularly something that we're interested in exploring, having three kind of professors and doctors in terms of going into the side of the patient and the side of how you've changed yourself, maybe personally, through doing the work that you do. I think would be really interesting to kind of explore.
I remember when we started the programme, and Fiona might remember this as well, there was almost a national giddiness about it. I mean, everybody was so excited about having this blood spot screening. So all the CF healthcare professionals, so we have teams who look after children with cystic fibrosis, they couldn't wait for their first baby to be identified, and I think actually that was a massive learning curve for us, because I think and this happened nationally, because I spoke to many colleagues across the country, and people would go into these initial processing of a positive newborn screening result. They would go in and say, everything's going to be okay, we've identified your baby's got CF, we're going to start the treatment now, isn't that great? And actually for the families it was crushing. So
do you think the relationship because of the newborn screening and because of it's altered the relationship between...
Yeah, well, they despise us now.
Is it really?
But the relationship builds in a different way.
Pre-newborn screening, oh no, there'd be huge variation, but roughly how many months after birth would it be before?
Yeah, generally towards the end of the first year of life.
So about 12
Not
months.
often beyond 2 years of life.
Okay.
Sometimes earlier, but rarely. So generally, as a child is, children as they're sort of approaching their first birthday are developing very different social skills and so forth. So it's a pretty key time, and then you impose a hospital admission or a lot of investigations on. It's a really difficult time.
And for those parents, again, I accept there's huge variation, but how many weeks, months would they have had their child before they might have started picking up? There might be something, because we talk about this diagnostic odyssey that lasts a while, but how long would they have had?
So now we have newborn screening. We recognise them generally at about 3 weeks of age, sometimes sometimes a little bit earlier. And the majority of children that we will see after newborn screening will have some small sign of them maybe not gaining weight as quickly as they should do.
Parents might have had a month.
So generally the symptoms of problem with gaining weight, eating well, drinking milk well, but not gaining weight, and possibly even being a little bit chesty sometimes, but that's unusual.
Okay.
So these symptoms can come on early doors, and there could be reasons why a family continually feel like they're banging against the door to say, look, my child is actually not gaining weight and going across centiles, or maybe gaining weight but not as quickly as they should do. I mean, going a bit off piece, but we had a very interesting, sometimes in screening, very, very rarely, the screening test is negative, but the baby actually has cystic fibrosis, and we call that a false negative result or an affected not detected result. That's very rare, but it does happen, and when it happens...
What are the consequences of that?
Well, it's difficult then, because the family have got a child with cystic fibrosis, but they've got a negative newborn screening result, so that might give you a false reassurance that they haven't got CF. So we had one family where that happened, and actually the health visitor was very good and started giving them high calorie feeds, and actually with those feeds managed to get the baby's weight to go up, even though the baby had cystic. So that health visitor being really very good delayed the diagnosis. But sorry, that's going a little bit off piece, but it shows some of the issues that we face. So now they come along and they have a well baby, as far as they're concerned.
That's the difference, isn't it?
And somebody's come to their door or phoned them up the day before, and we can talk about that indeed. And they come to the CF team, and then we have to start unpicking the fact that their child has got a lifetime condition, a genetic condition that's going to go on for the rest of their life, and their life is changed.
When you say somebody, I'm going to have to pick up on that, has knocked at their door or called them, so how does that happen? Why do they come to you?
So screening, we have an amazing sort of screening network in the country, and that's run through screening laboratories.
Okay.
And they organise in a really good way for the children to have the blood spot collected. So that's done by a heel prick sample. For cystic fibrosis, the way we process the result is that the lab contacts the local centre, and they will organise then for the result, the newborn screening result, to be delivered to the family.
Soon we will hear from Professor Rebecca Bennett talking about choices, and Dr. Fiona Ulf about the psychological complexity around newborn screening. Keep listening.
Just to be clear, Becky, this might be something that you might be able to help with, and my memory is a little bit blurred because when you first had a baby, I don't quite remember the first kind of couple of weeks anyway for most children, but every child has the heel prick. The blood spots.
Some
Not necessarily.
some
doesn't?
parents might refuse to have it done, and that's quite complex, and it might be around the fact that there's genetic components within the blood spot testing.
So tell me about that then. What the decision around that?
I think you need to be careful about the language, because refusing sounds like they're doing something really necessarily that we're putting value on. So we would say that it's a choice, but we found in the research that Fiona was doing with me that a lot of parents didn't understand that it was a choice that they made, whether they participated or not. So it is a choice. You don't have to have the test. You don't have to have the heel prick. You don't have to have the screening for your baby. So it's supposed to be informed consent like any other informed consent, and part of informed consent is that you can say, no, sorry, I don't want to have that.
So that was why we were quite interested in newborn screening from a psychology and an ethics point of view. So we have numerous screening programmes in the UK. Screening in its own right is quite an interesting model because it switches what people think of as healthcare. So a lot of us think you've fallen off your bike, you've got a sore knee, you go and seek something, or you've got some sort of symptom and then you go and seek help. And screening's kind of turning, when it's population screening, it's changing it round, and someone somewhere is sitting there thinking, we want to approach people who may not know they're at any kind of risk, and we want to talk to them about, so you're changing that healthcare model for a start. And that works, it still has its issues, but it works phenomenally well when you're talking about something like breast cancer screening, diabetes screening, bowel screening, because you're targeting specific groups of people about one condition. is it possible to get people to take on information about 9 to 10 different rare conditions simultaneously and make a decision about a unified screening program? It's also complex because, for the very reasons you were saying about, I don't really remember the first 2 weeks of my child's life, is very common. And that's when we're currently asking parents to make a decision.
What determined the 9?
So there was a pilot study that was conducted. Kevin might be able to speak better than I can to this. So basically, on any of the conditions, they have to meet criteria that it is sufficiently serious, that there is an argument that actually bringing in the treatment earlier. So the whole ethos behind newborn screening is that if we wait till the children are symptomatic or go through the diagnostic odyssey, they could already have been put at harm. And that might be harm we can't undo. And certainly for some of the conditions that have been added on, we are talking very, very short windows of 24, 48 hours a week where you can intervene and actually potentially stop that child from dying. So
that would be the criteria,
that it has to be something that is seen as severe, that is seen as that there is a medical treatment that can be done, and there's an argument why you don't delay that for symptoms.
So I might have sounded a bit when I said the parents refuse, but I kind of feel that parents have the right to refuse, and they should have a really good informed background on which to make these decisions. But actually, then you're taking away the autonomy of the child. There is no autonomy for the child in newborn screening because they're not able to decide whether they're screened or not. More recently, some of the conditions have not had that balance of so just to use and it's the condition I know the best, but cystic fibrosis. We had studies in the 80s and in the 90s, and those studies, the results of those studies were not providing a strong evidence that actually screening is of benefit for those children in the first 10 years of life. What we've consequently found in longer term studies is actually what we do in these early years then begins to have impact on how these children are as adults. And how
that's the key, isn't it?
Well, it's really complicated, but it's actually...
But it is really complicated, but it's the interesting... I'm in an interesting situation with the condition that I have, that there is a drug being developed by different drug companies. Pharmaceutical companies, that's the word. To treat achondroplasia, and our definition of treatment might vary, but their main goal is height. So this drug will increase height potentially. And similar to what you were saying before, there's a thinking around the earlier that the baby receives the drug, so the earlier that they're diagnosed with achondroplasia, the better, because then they can start receiving this drug, and eventually the theory, and it absolutely is just a theory at the moment, that it will prevent long-term health conditions associated with achondroplasia. But in terms of what you were saying, nobody will really know that until the children that have received that drug and a child that hasn't has reached adult life. So that takes a long time, doesn't it, in terms of studies and kind of foreseeing a future for your child that might actually be very different to what a health professional or what somebody is predicting.
Can I just check with you? There is a clear idea medically that there are some good reasons to do this screening. I know this is part of the...
So tell us, is there that again?
Before we just imagine that with one condition or one condition we say we agree with that. Okay. Let's imagine we agree with that. Still, there is complexity in
the carries is.
Well, that's it. I think, and so just focusing on cystic fibrosis, and I know Kevin's done a lot of work and a lot of campaigning around this as well. But I think that goes back to our idea previously we were talking about that these things are socially determined. So the other reason why we're interested in it as psychologists and ethicists is the examples we talked about so far have been that someone is walking around in the population or is yet to be born and has that condition anyway. And screening is just identifying it and opening decisions. What newborn screening brings in terms of complexity, and it happens around cystic fibrosis, and it's also very prominent around sickle cell screening, is we are not just saying your child, the only outcomes of newborn screening are not your child has no condition or your child has condition. We are also returning carrier results to parents. So we are telling to parents along the lines of, to try and kind of make it blunter than it actually is your child is healthy, but they carry one of the alterations linked to a particular condition, and that may have reproductive decisions for you as a couple, and it may have reproductive decisions for your child. And that actually contravenes guidelines around carrier testing in childhood.
Increasing data now to support that newborn screening has overall had a very positive impact on the life of people with cystic fibrosis.
Whole being, or not just physical being, but kind of.
So are they psychologically better adjusted because they were diagnosed? I don't think so. I don't think we have any evidence around that. But what we have shown is that people with cystic fibrosis who are well enjoy better feeling of well-being, mental health well-being than so we have shown there's a relationship there. Not a complete relationship, because some people with cystic fibrosis can have really severe physical illness with chest infection, but actually have very robust, strong mental health.
The family discovers some pain or some difficulty, some problem, and then they call you. That's before the screening, and then you are part of their team in discovering and helping and supporting their journey. But now you are stepping before. The screening means that you are telling them, you're not in the team from the beginning, you're not in the team against this problem. Or
for me as a psychologist, it's fascinating because I think it comes back to this idea that we came across when we were doing the work with CF SPID as well, that some of what newborn screening is doing is throwing into sharp relief the mental models people walk around with about what health and illness are. What does it mean to be well, and what does it mean to be ill, and when is it appropriate for specialist teams to intervene? And almost it's this irony of newborn screening is that the more you need newborn screening, the bigger impact it can actually have on that. So if you have an outcome, a situation where without medical intervention, that child will start looking very unwell. But you have this dream scenario where you can bring in treatment just before that happens, and the treatment is so good that you can keep them as fit as a butcher's dog, as you're saying, kind of thing. You almost will get parents questioning more. The better you can keep that child looking well, the more the parents are going to ask, why are you so involved in our lives? And again, I think it goes back to these models of we have what I would call are now slightly outdated societal models of how healthcare should intervene. And we're not quite working on the preventative model, although the healthcare system wants us to. People struggle with the idea that you may have specialist teams involved in your lives to prevent harm. Does that make sense?
Yeah, but I think it also goes even a step before that, which is when you're pregnant or having a baby, and every single person that I know has said this, I don't care whether it's a boy or girl, just as long as it's healthy. So everyone proceeds, that pregnancy with everyone. I don't know anyone that doesn't, that's the only thing that they think that they want is for a healthy baby, and we've got so
But what do they mean by that?
Exactly.
Yeah.
And that's the interesting thing, but people say it without thinking, and they say it to somebody even with conditions without thinking, as long as my baby's healthy and got 5, 10 toes and 10 fingers, And I think that's this little step before about what we perceive healthy to be, the impact that has on our lives, on our children, on how society perceives them as, we want this strong baby that's kind of going to conquer everything because they don't have a health condition and they're not going to therefore get bullied at school. You think so far ahead of your child's narrative, I think, when you're having a baby. And health is the first thing that you have on your wish list.
But it means that you've got a very captive audience there. So one of the things that was kind of maybe surprising with the work that Fiona's team was doing was that we kind of found that lots of people didn't know they could refuse, lots of people didn't feel like they'd got the right information. And you can understand in order to get a high uptake of this screening, trying to give complicated information and telling people you can refuse the test, you could say no to the test, might be something that people felt difficult around, because we want to get this high uptake of the test. But actually what Fiona's work found was that people were saying, well, actually, given that I'm worrying about my baby and I'm a pregnant woman and I'd probably do anything in order to make sure this child had the best start in life, I probably still, if you'd have explained it to me, I probably still would have consented. I might have been even more likely to consent to it. And I would have felt that I'd been respected as a human being a little bit more if you'd taken the time to explain what was happening. Because I talk about this issue to all sorts of people. I talk to genomicists and people who really know all this stuff really well.
Come on to that later. I'm very worried about
I'll talk about newborn screening and how many things are now being tested for, and that they retain this sample of your baby's blood. And I just did it last week, and this guy who's a genomicist has just had a baby and went, really? I didn't know that. And he looked really horrified. And the thing around consent is, the idea of informed consent is that we try and respect people's choices. And we think it's important that people in our society get to have choices about what happens to them, and in this case, their very young baby. We will not always do that. So if somebody came in with a horrible infectious disease, we would say, well, actually, your choice to run around Manchester with this condition might not be one we respect it, because we want to prevent the huge harm that could be happening. And that's kind of what's happening.
Baby as well.
Well, yeah, that's what's happening in screening often, is we say, yes, well, as Fiona was saying, it's a different way of looking at healthcare. So instead of opting into something, you've kind of got to push back and say, no, I don't want to have it. And we know by doing it that way, you'll get more people who go through screening. But it also means that it's a different kind of quality of consent than the usual consent that you gave if you go to your GP and you want a genetic test for other reasons.
So why would you say we need more? What would you say we need more in terms?
Conditions.
No, more in terms of how do you inform people? How people...
Well, that's a lot of what the work the project that me and Fiona have been working on was to really think about this, because, you know, you could go the other way and say, look, this is like something that we don't normally, we accept a different kind of consent model to. So it's something where you're protecting people and quarantine people, or that, you know, in other countries, they've gone much more towards that kind of, that this screening's more mandatory, and it's extremely difficult to opt out of it.
We hope you are enjoying the podcast so far. Please subscribe, rate and review. Continue to follow our conversations where we discover that rare means different things to different people.
Can I just check with all of you, and it might be part of the same bit of the conversation, are we taking into account the people in the margins of our society? Are we talking only middle class people here?
But this again is why newborn screening is so interesting, because in newborn screening you are trying to I argue that we should be trying to communicate to every single person who is having a child in this country. And that's a hugely diverse population. But also the reason why newborn screening is different again from other screening programs. Yes, for breast cancer screening, you might go through multiple times, but it might change as a breast cancer screening program, but it's still breast cancer. Whereas in newborn screening, what parents aren't always being made sufficiently aware of is they might have had, I would have had, a blood spot taken when I was a baby for PKU. And then I go, oh, they're going to come and take blood from my baby to my mum. And my mum goes, oh, don't worry about that. You had it when you were a child. And what people aren't realising is generation to generation, newborn screening is changing. But even within one woman's reproductive lifetime, she could have a child 1 year and it's 4 conditions, and a child another year and it's 9 conditions.
Why?
Because the newborn screening is expanding.
Right.
So we've gone up to 9 in the US. I think they're up to 40 in some states, 30, 40.
30 in some states.
30.
It's very variable in the US and across Europe as well. There's variability in the number and type of conditions that are looked for. Yeah.
So within that, it's fascinating from a kind of communications ethical issue of the decision you made in one pregnancy could be quite a different decision you're making in another. But in terms of when you're saying, well, how do you communicate about that? And I thought it was interesting you were bringing up some kind of almost echoes of what's being said about COVID right now. Is they've got a lot of health psychologists involved in how do we get messages out to the entire population to actually do effective behavioural change around containing this condition. And what I think
talking about the coronavirus.
Coronavirus, yeah. So what I think is really important there is they keep saying it's so important the timing of these messages, and it's so important you bring the public with you. And what we were arguing in our newborn screening information is, yes, there's a message you want to get out there for newborn screening, but what's crucial is you look at why are you talking to parents about newborn screening? And within England at the moment, it's because we want them to make an informed choice.
Maybe, the role of a genetic counsellor could be a type of a role that can be in many hospitals, or maybe
This is really
working
interesting.
together with
Yeah.
doctors.
Just to clarify
Yeah.
that genetic testing is not in all newborn screening. It's only in certain conditions. Cystic fibrosis is one of them. Sickle cell disease in most areas is another one. And that has, by incorporating genetic testing into the screening program, it's kind of opened up a whole can of worms. Pandora's box. It's then put us in a situation, and when these programs were being advocated and people said this is the way forward, and there are great advantages to incorporating genetic testing, because it can make a screening program much more precise, much more specific. It can make it a bit quicker as well, so you can sometimes identify a baby more quickly and start the necessary treatments in a more proactive way. But it does then open up the you recognising carriers. Now that was presented as a very positive thing by the lobbyists, the evangelists about screening. But I'm still I have some anxieties, Becky, around perception of carrier status just generally in the
Well, that's why I mentioned it, because whereas we know this kind of consent is always going to be slightly different from the normal kind of consent, but it might be that if we've got all this really good evidence, in the same way as pushing people towards breast screening or cervical screening, we kind of think, well, it's justified to put that bit of pressure on them because we know that the outcomes are usually very good and the sorts of things, if people really understood what they were screened for, that they would want to do. But carrier status puts us in a different area where knowing about that really early doesn't have that same power of harm reduction and that evidence behind it that's necessarily...
I mean, the baby will be well,
and
very just fit and healthy and well. They've just had a
and we've got 9 conditions at the moment, and there's lots of other places that've got many, many more, and it's around, there's that kind of impetus from the medical world of wanting to know as much as possible about these children, including retaining a sample that we can do even more work on, but at the same time recognising that we normally say that parents can make these choices, and we need to kind of weigh those two things up and say, does that mean that we can put pressure, even if it's a very gentle pressure that you can refuse, onto people to have all these conditions, or is it about really seeing where the evidence of harm reduction can be seen, and that might give us that reason to put that little bit of pressure on people to take a different choice than maybe they would have opted into.
The medical argument for that you hear as to why newborn screening might want to identify carriers is that for both, I'm just saying this in front of Kevin, and I'm like, oh, if I get this wrong, but for both cystic fibrosis and sickle cell, if the child is a carrier, then at least one of the parents is a carrier. So it has inferred information.
You're opening that way.
Counter arguments are, if parents want to make informed reproductive decisions, then why don't they access carrier testing separate from newborn screening? But an argument for why. So what's interesting, and where I said earlier Kevin's been involved in, my understanding in the cystic fibrosis protocol is basically you could shift, and this is where my lay but you could basically shift parameters and it would alter how many carriers you would identify via newborn screening. And cystic fibrosis has made a decision to limit the number of carriers.
I think the general European philosophy would be that it's better to have a programme where the number of carriers that you identify is as small as possible. Whereas in other parts of the world, particularly in the US, actually they're more likely to say, we don't mind recognising the carriers.
And I think you have to be careful about what precedent that sets, because there's all sorts of information they could find from that blood spot. They could sequence your whole genome now. They could find out all sorts of things.
Some talk about doing
and I think it's very likely that that's going to be something that at least is on the table very soon. And the same argument could be used. Well, it might be useful to you to know these things. It might be useful to know whether you've got a predisposition towards breast cancer. It might be useful to know if you've got a likelihood of developing a genetic disorder. And the problem with saying, well, this might be useful, we don't know, but it might be, more information is good, is that it assumes that everybody agrees with that. And we know that lots of people don't want to know that information. And if we really try and respect people's choices, we've got to be careful about making decisions for other people about what we think that is good for them, because it takes you back to that kind of idea of somebody else making your medical decisions.
It's that paternalistic idea, isn't it, that somebody is making a decision that they think is right for you. And I think that's interesting anyway as a parent, because throughout your children's life at some point you are making decisions that they can't make. Health-wise as well, I'm going through something with my eldest daughter in terms of an interventive operation that she needs to straighten her legs. I'm making those decisions currently for her, and until she says, actually, Mum, I'm done, she's trusting that I'm making those decisions. And although it doesn't seem as extreme, it's the same principle that I'm making a decision about her health on behalf of her, because I am her parent.
You are, but if it was the state or the health service that was making that decision. So that's why this idea of respect for autonomy is seen as being so central in the sort of society that we live in, because we see that having that choice over our lives is something that's really, really important. We could live in a society where nobody gets this coronavirus that's going around, that everybody knows whether they've got carrier status for everything, where everybody knows whether they're likely to get all sorts of genetic disorders that might be treatment for. We could live in that society. Everybody could be tested for HIV, everybody could be tested for all sorts of conditions, but that's usually not the sort of society that we aspire to live in.
Can you say why you think
that's what I want to know.
Why?
What's the consequence of that? Why do we not want to live in that society?
Well, I often use the example of thinking about Huxley's Brave New World, this kind of dystopian world where everybody's well, they all have homes, they all have all the sorts of things that kind of, from that public health medical kind of view, they all, if they've got conditions, they get treatment, they get treatment just when they need it. But we don't aspire as human beings to go in that direction. Not very long ago, maybe 25 years ago, my colleague who was an oncologist says if somebody had a terminal diagnosis of cancer 25 years ago, you probably wouldn't tell them. You'd probably tell their family, but you wouldn't tell them. And the shock and horror on people's faces when they imagine that they wouldn't have that control over their own information and their own medical care, you see it in people's faces now. And it's because even if you might be saved distress of knowing that diagnosis, we feel it's important that it's my life and I get to say what I do about it.
I know it's about time.
It's very, very important time at
this
point.
Oh, okay. So I have one more question and then the rare question. Have we got time for that? Or
okay, I don't know. Yeah, go.
My one more question was to each of you, and it was something that you picked up on at the beginning, and I just wanted to ask it again, really, because we didn't really go into it, which was almost like looking through the long lens of your, professional career, and particularly regarding cystic fibrosis and newborn screening. And I'm going to ask each of you this question: what's been the one thing that's kind of stood out, that's changed almost your personal perspective?
That's not an easy question. So I think when we started in sort of about 20 years ago with great gusto in trying to organise newborn screening, I had very little perception of how many, the significant number of children that we would recognise with an unclear. So these children we've now called, we've a designation of CF screen positive inconclusive diagnosis, which Fiona shortened to CF SPID, which I don't like very much.
But everyone does.
But everybody does. So these children are, I think, are in a very tricky situation. Their families are, because it's very unclear. So I don't think we had a perception of the magnitude of that issue, of that, well, I don't like to call it a problem. These are healthy children. And I don't think we've managed it very well. Most of these children have been actually treated as if they have cystic fibrosis. We've changed that now because they're well children by definition. So that's been really tricky.
I guess when I had my child 16 years ago, but I was already working in this area, and I was really fascinated to go through that process myself and see whether the things that I had been talking about that I thought were happening
Did you
were.
read the booklet?
I tried to read the booklet, but it was, and we know that it's quite difficult to say no to any of these screening tests, and it was difficult for me, and I really did try and push back on them. And to be in that situation is when you know as much as I probably do and still find it difficult to refuse screening, shows that there is this element of pressure there. And I didn't feel that I was necessarily being informed as well as I could do, but I also recognised the difficult job that midwife who was talking to me had. It was almost an impossible job.
So I think as I said at the beginning, I think my interest has always been about people making decisions that fit well for them. And so in my early years, which sounds a bit daft to say, but I was quite often asked, Fiona, do you think we should be identifying carriers? And my answer was always, that's not my area, and I'm simply interested in, are we giving people sufficient information that they're aware that that's what's happening and can make a decision. I think for me, what I've found as a kind of shift change slightly though has been some of the work that's coming out now, where we're looking at young adults and how young adults are going to interact with other young adults who are carriers, or how children who are carriers and are trying to have conversations in romantic relationships, etc., and looking at the impact that is having on those young adults. I found it hard to sit there and not say, if we don't change things massively in society about how carrier status is perceived, we're actually doing a lot of harm to these people. So yeah, I think that was my shift change.
Thank you. I know we were stuck for time, but I'm really glad I asked that question.
Oh, yes.
And we have one more.
One more question.
Which we ask all of our guests on every episode, which I'm sure you've all tuned into every month. Or
So
about to.
I will, from now on.
From now on,
subscribe
you'll be our
and,
avid listener from Liverpool.
So we talk about REA a little bit. What REA means to you would be the question we have for you. It could be anything, and hopefully not related necessarily to your profession, but this concept of REA, what REA means to you.
Should we start with Fiona, because you have had a little bit more time to think about it because you're on our team. So then it gives the other two guests a little bit of time.
So when we first had this discussion, the immediate image that sprung to my mind was a pearl. So I thought of it as something very unique, something valued, something special. Working on this project, but also having some more recent experiences, personal experiences of rare conditions, unfortunately, I think rare now can be seen as a reason for silence. So either not engaged with, or your voice isn't heard, or your voice is silenced. And I think that concerns me.
I guess when I'm thinking about it, I am thinking about that. Trying to not make rare feel isolated or something. That, you know, we were talking about how society can put different negative connotations just on the way that the collective feels about people that they feel are other to them. We were talking in the kind of staff room earlier about this coronavirus and wanting to know that it affects people that are different to us. So it's always reported they've got underlying conditions, and we all think, oh, thank goodness for that. That's not my group. That's not something I need to be concerned about. And for me, that's what worries me about things that are seen as rare, is it makes the big group of powerful people think, well, I don't need to worry about that, or I can carry on having quite biased views about those kinds of groups. So for me, it would be about trying to really question that and change that and get people to see that we're all rare in one way or another, and that we're all part of that same group, and to just change that perspective a little bit.
That's really interesting around, that coronavirus. Oh, it's not going to affect us.
It won't be us.
I think it's been very, very badly presented. So as I mentioned at the start, I'm a doctor, so when I consider rare, as I've been a doctor for longer than you might think, it's actually something that happens far more frequently than you would expect. And this is what I teach to medical students now, and I say, look, your lives are often going to be very mundane, but rare things are going to come along more frequently than you expect, and you have to be open-minded and you have to expect them, because otherwise you'll be caught out, or you'll have so you'll be caught out. Yeah, so that's to me what rare is.
Thank you. And actually, all of what you said ties into everything that we've talked about in this episode and outside of this room, and the really interesting new perspectives actually in terms of what we always said from the beginning, that rare isn't actually that rare. So, first of all, I obviously could have kept talking for much longer, but I think it was really interesting, and it turned out different to how I expected. I possibly went in with a few preconceived ideas of what the conversation and the discussion would be around, and actually it all came back to what it always does, which is our perception of rare and how that impacts all of us.
Yeah.
And as long as we have the correct information, then we all should be able to make a decision that impacts our lives or the lives of our children.
Well, I also think there's more questions that had left me with, questions around how is these ideas in society get decided, and how power plays a big part of how things are understood in society, and what society is, what health is. I also was aware that in the conversation, maybe some people might not felt completely included. We talk about parents, mothers and fathers, and sometimes, I don't know, couples that they are two mothers or two fathers, whether they felt included or not in the conversation. So I would really like to hear from people who listen to us and maybe have something to say about that.
Definitely. And I can only imagine, I mean, I mentioned it a few times in the podcast, but I genuinely don't remember going through newborn screening.
Yeah.
You know, I remember prenatal, but I don't remember newborn. And I consider myself somebody that was, you know, felt quite informed and felt quite in control of my pregnancies and in control of my birth. So I can only imagine what it feels like, possibly for somebody that's also new to our country or has moved here, and there's communication. I mean, you know yourself in terms of if you are dealing with all of this in your second language. And different cultures and different ideals around those cultures, it must be even more difficult to make them decisions. And like you said, the concept of power, that if somebody that is considered a professional is somehow, you know, communicating this decision to you, and how, whether you should take it or not, or what are the consequences of this decision, that also, I think, affects your response.
Absolutely. Well, it was good.
It was. This podcast has been made possible by our brilliant team.
Rona McLeod,
Ramona Moldovan,
Jay Roach,
Maria Angels Ferrer,
Nicola Garda,
Fiona Ulf,
Nick Jordan.